am a researcher at Chang Medical Education Research Center here in Taiwan. And today I'm going to share a little bit about a Q methodology study we recently did on the perceived value of formative feedback in CBME. So a brief overview of everything I'll go over today, the background of our study, the methods, the results, and implications moving forward, sorry. So a little bit of background. We all know that formative feedback is really important in CBME as it it bridges the gap between skills that students are still learning and skills that students have already attained. And so it bridges that gap between them so they can kind of understand where they need to work on, and also is a reflection of the instructor's teaching styles, because then it gives instructors kind of this idea of how they're teaching and how they can improve their teaching so that their students can learn better to become better physicians. And why we kind of focused in on Taiwan and emergency medicine. So around 2012, 2013, there was a huge medical education reform where the education system switched medicine from a 7-year program to a 6-year program. And so from there in 2014, Taiwan was named the ACGME International Facility Development Hub. So CBME was introduced in Taiwan and emergency medicine training programs. And so now that a couple of years have passed, we kind of wanted to look at how it's doing amongst the residents and among instructors, but primarily residents in this study. And so, like I said, the aim of our study was to investigate the perceived value of formative feedback following this medical education reform and implementation of CBME in emergency medicine residents in Taiwan. And so for our methods, like I said previously, we use Q methodology. And for those who are not familiar, it's a mixed methods approach used to explore the subjective attitudes and viewpoints of an individual within an operant framework. And so we asked our participants to sort through a set of statements. In our case, there were 60 statements, and asked them to rank them on a forced normal distribution grid from 1 through 13. We chose 13 just based on the number of statements we had in the end. And I'm actually not going to deep dive into this because later in today's microconference, Dr. John Wei PI will actually discuss the concourse development. And so within this study, we had 32 emergency residents that ranged from their 2nd through their 5th year of residency training. They came from 11 different hospitals, and we had to conduct all of these over Zoom due to the ongoing pandemic. And by-person factor analysis was conducted to extract the viewpoints in R. And so we used Fairmax rotation and principal components analysis to extract these factors or viewpoints, as we call them. And so for our results, of the 32 total participants that we had, 27 of them loaded onto 4 separate viewpoints. They were primarily male, and they were all mostly in their 4th year of residency. And so in the end, we had a 4-factor solution. And so the first viewpoint, the participants wanted specific and comprehensive feedback, which is pretty much the most generic feedback anyone could ever ask for, which is just wanting to know what they did right, what they did wrong, and how to improve on these. Viewpoint 2 focused a little bit more on this idea of safety and trust. And so they wanted feedback to come from them in a safe environment, away from their patients, away from family members, where they feel that they can speak openly about any concerns they may have had with the way they're performing, or to have their feedback provider also let them feel safe that they can openly talk about these things. Viewpoint 3 focused a little bit more on the timing and the source of the feedback. So they really valued feedback that was given to them close to within the same day of their performance on a procedure or their behavior, so they can kind of understand and remember exactly what they had done and what they need to work on. And also from someone that they found to be respectable in their field, whether it be an emergency physician or otherwise. It just has to be someone that they felt was worthy of giving them feedback. And then the last one was viewpoint 4, where they cared a little bit more about self-reflective feedback aimed towards a professional goal. So they wanted feedback that was quite specific to a direction that they're going in, whether it be in a subspecialty or otherwise. They just wanted to really be like, I'm working towards this goal, help me get there. And so that was the feedback that they kind of focused in on. And so of these 4 viewpoints, we found that they kind of revolved around 2 major ideas. And so the first one being the content of the feedback. They really just cared about what was in the feedback, whether it's specific, about a procedure or a performance that they displayed while they were in practice or even actually with a patient. And then the second one, they kind of focused on this idea of when, where, and who. So when it was delivered, whether it be in a timely manner, like right away, or if it's delayed. They cared about where they got it from. They want it to be in a safe learning environment, like I mentioned previously. They wanted to be in a place where they could kind of not be around their patients, because one of their concerns was that if a patient heard that their own doctor is kind of concerned about how they're performing, the patient wouldn't feel comfortable coming back to this hospital. And the last one, they valued who delivered the feedback, whether it's someone they trust, someone they respect, or someone that they share a long-term relationship with, which is really not common in emergency medicine because of this rotating shift schedule that residents and attending physicians are on. And so it's hard for them to get that long-term relationship, whether they do research on the side with them or they specifically align their schedules to be with specific attendings. And so that was something that was unique among emergency medicine residents that we don't really find in literature. Other specialties are constantly with the same attending throughout the residency period. So in emergency medicine, it was just a very different side to see. And so lastly, just the implications of our study and kind of moving forward. We know that formative feedback is a two-way street that allows for both for attendings and for residents to kind of improve on how they teach and how they learn. And so this study, we kind of hope that it could lay the groundwork for future curriculum reform, whether it be for attendings as they learn to become better educators, or for residents to kind of understand and go through their own self-reflective process, like learning process when they gain feedback from their instructors. And yeah, sorry if I talked really fast, but thank you for listening.
First is my background. Service learning in remote communities is a valuable experience for medical students. Many studies interpret have presented benefits, such as gaining interpersonal skills and acquiring both academic and professional skills. But within the Asian context, this is mostly student-initiated and voluntary. The Integrated Delivery System, IDS, emerged in the 1990s. They integrate local healthcare providers with outreach services provided by contracted hospitals. In Taiwan, our government adopted this concept and has implemented 50 programs for people living in remote areas since 1999. Our study focused on one service learning group in Chang University named Lokada. Its goal was providing assistance to remote Fuxin Township. Before IDS, the consultation project conducted by medical students were highly regarded and supported by the remote indigenous communities. However, with the expansion of IDS and improved primary care, demand for volunteer medical services from students have decreased dramatically. This change has challenged the value and direction of service learning. As a result, we asked how a student-led service learning group negotiates its position and responds to the tension of changing models of service delivery and demand within a rural indigenous community. That is, we like to explore the interactions between medical students, rural villagers, and the governmental sector. We conducted a qualitative study and interviewed 18 current or former medical students of Lokada. Chat was used for conceptual framework. First, we used inductive analysis. Then we built up second generation activity system of volunteer medical consultations project. However, this did not fully interpret the dynamic changes under the context of IDS implementation, because it could not present two mutually influencing activities, that is, medical students and indigenous communities. Therefore, we used a third generation activity system. In Figure 1, it represented the tensions between the intrinsically formal characters and their primary objects. broken arrow represents disruption in their shared outcomes. Through chat, we found that ideas can be viewed as a disturbance to the existing volunteer medical consultations project. This forced students to question current practice and engage in an expansive learning cycle to bring about transformation. Medical students found that their service were not meeting the demands of local villages. Therefore, let's suspend volunteer medical consultation project in 2008. Instead, a new model of service delivery was proposed. Several community-centered projects based on local demand were established. Locata shifted its goal from providing pure medical services to a multi-dimensional project. This was a dynamic change as indicated in Figure 2. And Figure 3 is our third-generation chat. There is a shared focus between two previous disconnected and misaligned activity systems. Both medical students and community residents can benefit from the service learning project. It's a win-win situation. For brief conclusions, the most important findings of our research is that expansive learning among medical students helps them shift from a biomedical to biopsychosocial model of service. Flexible goal setting and coping ability were critical for university service learning groups to survive and maintain their vision crossing various value systems. And this is the end of my presentation. Thanks for your attention.
谢谢. Thank you, Chia-Yu.
I'm a lecturer of medical education at the University of Newcastle, and today I'll be speaking about our project which compared approaches to teaching clinical skills in the early preclinical years of a medical degree. The context and motivation for this project stemmed from the fact that the most appropriate timing and mode for teaching clinical skills as preparation for medical students' clinical rotations is not widely accepted. Due to the increasing pressure on placement opportunities, there has been some shift towards simulation-based teaching in the early years of medical training. A major curriculum redesign in our medical program included a shift from ward-based learning of history taking and physical examination skills, facilitated largely by practicing clinicians in the Bachelor of Medicine program, to primarily simulation-based learning in the classroom in the Doctor of Medicine. The teach-out of the BMed program and concurrent rollout of the MD program provided an opportunity to investigate differences in the students' learning associated with the two approaches. Our first data collection point occurred prior to the first predominantly clinical year in both programs. This included students entering Year 4 of the BMed and Year 3 of the MD program. To investigate differences in their clinical examination and communication skills, students were invited to take part in a series of objective, structured clinical examination stations, which included clinical reasoning questions. Students were also invited to complete an online survey exploring their sense of preparedness for clinical rotations. 12 months later at time 2, the same students were invited to repeat the survey with some additional reflective questions, and the MD students were invited to repeat the OSCE stations. In the interim, students were also invited to participate in focus group discussions or interviews to further explore their clinical practice, experience, and preparedness. Overall, our findings supported the simulation-based approach taken in the MD as preparing students to at least an equivalent level to their previous program. A comparison of skills demonstrated in the OSCEs revealed mostly no significant difference, with a slightly higher performance by MD students on a number of components. For the Preparedness for Clinical Rotation survey, the students in the MD program demonstrated equivalent self-reported confidence and preparedness to the students in the BMed program. Interestingly, the BMed students were consistently more confident than their MD counterparts at time 2, despite being less confident among this group at time 1. Now, this could be due to the increased total length of clinical experience or volume of medical science learning among this BMed group at the end of Year 4, or potentially the influence of a more structured preclinical curriculum and learning points for the MD students. Analysis for time as a single factor showed that both groups had substantially increased their confidence across all skills from time 1 to time 2. Both cohorts expressed a general sense that the best preparation for the hospital environment was to be immersed in it. Students generally agreed that clinical examinations learned in the classroom prepared them well for the partial examinations more commonly required of them in the clinical setting. A particularly common theme raised by students was the feeling of being unprepared for or lacking experience in answering questions asked by clinicians verbally. In terms of the challenges and limitations, while there were good participant numbers and as well as age and gender representation from the MD cohort, the BMed cohort participation was low, and the females were overrepresented compared with the whole BMed cohort. Furthermore, there were a number of additional differences between the programs at time 1 to consider, including larger group sizes in the MD with 7 to 9 students per group, compared with 4 to 5 in the BMed clinical groups. BMed students had engaged in 6 weeks of general practice placement, compared with just 2 days for the MD students. And the MD students also had more formative OSCE assessment opportunities, additional summative OSCE stations, and access to OSCE rubrics prior to their exams. Overall, we concluded that the MD students are not disadvantaged in terms of their preparedness for clinical rotations. However, we have made some improvements based on the insights gained from this project. In response to students feeling unprepared for being asked questions verbally by clinicians, we have since added some clinical questions into the preclinical OSCE stations. While these questions don't contribute significantly to the overall marks, they provide a practice experience. We have also been adding more clinical reasoning activities into the simulated environment. Thank you, everyone.
All right. Yep. Hello, my name is Carmen Abeyaratne and I'm a lecturer at Monash University, and I'm delighted to be able to present my talk titled Development and Validation of Entrustable Professional Activities, or EPAs, for intern pharmacists in Australia. So in 2019, the updated accreditation standards for pharmacy programs in Australia was published by the Australian Pharmacy Council, which was accompanied by a performance outcomes framework. The performance outcomes framework provided supporting documents that detailed a range of assessment methods to assess interns' capability to carry out professional activities. For the first time, EPAs were recognised as a workplace-based method of assessment for intern pharmacists to demonstrate specific performance outcomes. So the purpose of this study was to develop and validate EPAs for intern pharmacists in Australia. So in the development phase, we identified which performance outcomes require EPAs as an assessment in the internship year based on the guidance documents provided by the Australian Pharmacy Council. These performance outcomes were mapped to enabling competencies from the National Competency Standard Framework for Pharmacists in Australia. From this, an EPA title and description was developed. The next stage involved the validation of the EPAs. The equal rubric designed for EPAs in graduate medical education settings was used to validate the EPAs. The purpose of the equal rubric is to assess the quality and structure of the EPAs developed. 8 subject matter experts with expertise in EPAs were recruited from academia, community, and hospital to validate the EPAs. Descriptive statistics for the equal rubric scores were calculated for each of the 14 EPAs overall and for each of the 3 domains. The 3 domains were discrete units of work, entrustable, essential and important tasks of the profession, and curricular role. Any EPA that received an overall average score below the cutoff of 4.07 or below any of the domain-specific scores were revised and presented back to the subject matter experts for a second round of validation. So here is a snapshot of part of the published equal rubric that was used to validate the EPAs. So each question within the rubric has 5 responses with descriptive anchors scoring between 1 to 5. So now we'll move on to the results. So here we have the overall and domain-specific average scores for the 14 core EPAs developed for intern pharmacists. Any EPA highlighted in yellow fell below the cutoff score for domain or overall score. So these EPAs were revised and given back to the panel to answer the same set of questions again for the revised EPAs using the equal rubric. So the scores for the seven revised EPAs, coloured red and green, compared to the original. So all of the revised EPAs scored above the overall cutoff of 4.07. You'll notice EPA 10, 11 and 12 highlighted in yellow just fell below the cutoff for domain 1, but overall the score improved, so we decided to move forward with these ones as they were. So these are the final 14 EPAs developed and validated for the project. You can see the activity or title in bold and then a description of the activity. And this is just an example of 2 pages from the EPA guide I developed for the project to assist the subject matter experts when they're completing the equal rubric. Now we'll move into the discussion. So it's recommended during the EPA development stage that a tool such as the equal rubric be applied to assess the quality of EPAs. Applying a validation tool when developing EPAs ensure high quality in structure, both for the workplace and as an educational tool that assists the learner. It has been acknowledged in the literature that there is an absence of a standardized approach when developing EPAs, and the literature highlights that this should be a priority area for future researchers and educators. A limitation to this study was the equal rubric was originally designed for EPAs in graduate medical education settings, which may have impacted how the subject matter experts interpreted the rubric questions. However, all the questions in the equal rubric could be applied to the pharmacy setting. Further, the subject matter experts were briefed extensively about the rubric and were asked to view an instructional video about the equal rubric. So in conclusion, 14 EPAs were developed and validated for use with pharmacy interns in Australia. To our knowledge, this is the first time the equal rubric has been used in the evaluation and validation of pharmacy EPAs. Work has continued after the development and validation of the EPAs in this project. The EPAs were implemented across Victorian hospital and community sites and evaluated for utility and feasibility through focus groups and surveys. The entrustment level at specified time points were also reported. The findings from this study are being prepared for publication and will inform the profession about the future direction of EPAs as a method of assessment for pharmacy interns. Thank you.
I'm Yu Zhang. I'm from CG Merck in Taiwan. It's my great honor to present our recent research in micro conference here. The topic is bridging the gap, using consensus to explore entrustment decision and feedback receptivity in competency-based emergency resident training through the construction of a Q sample incorporating a Delphi technique. There is no conflict of interest. This is my outline today. Nowadays, assessment is a system problem. There is still a space. Graduate medical education assessment system is expected to be strengthened. As a valid assessment is a social responsibility related to all stakeholders, such as healthcare learner, faculty, institution, patient, and the society. Residents in training will receive feedback from individual clinical educator or clinical competency committee based upon synthesis or judgment of the learning information of resident in training. The committee is responsible to the public when entrustment decision of supervision level to patient care is given to health professional newcomers. To improve human judgment is considered critical to the quality of entrustment decision, also to the quality of patient care. A fundamental aspect of competency-based resident training is the decision to entrust a medical resident with the responsibility to care for a patient with minimal supervision, which require guided interaction between clinical educators, medical residents, and the patients. Feedback in clinical setting manifests in many forms. It can be explicit, such as given after assessment or focus on overall performance, or can be implicit, maybe related to body response and the reaction. Recent study consider feedback credibility and the reliability is necessary to bridge the gap between feedback and its intended outcome. The study aimed to establish a consensus on factors that affect a clinical educator's path to making entrustment-based supervision decision and the factors that affect the medical resident receptivity to feedback received. We used a four-step approach, a systemic way to develop a 2Q sample to explore the factors that influence entrustment-based supervision decision among the clinical educator and also a feedback receptivity among medical residents. 2 rounds of Delphi Technique was employed to achieve expert consensus. We have built 2 expert panels, one for 12 clinical educators and another one for 13 medical residents invited from different specialties. Participants were presented with a sample of statements and instructed to rank their opinion of each statement on a 5-point Likert scale. We use model of trust to be the conceptual framework of the entrustment decision-making process by which we analyze our data generated and categorized statement accordingly. For feedback receptivity, we use the Ready, Will, and Able model with theory of self-regulated learning to analyze the data and generate the statement. The initial statements were extracted from literature search and the semi-structured interview. Totally 585 statements were extracted regarding entrustment-based supervision for clinical educator, and there are 1,039 statements were extracted regarding feedback receptivity for emergency medical resident. After 2 rounds of the Delphi Technique, a panel of clinical educators agreed on 54 statements, while another panel of medical residents agreed on 60 statements, which Renee has been addressed earlier. This is a flow chart. Our research team extract the statement and achieve the consensus. This present study helps us to understand factors that influence entrustment in supervision decision and the feedback receptivity by establishing a general consensus among clinical educators and the medical residents respectively. This study also provided deeper insight into entrustment, supervision, and the feedback receptivity in the clinical context. Though not exhaustive, the key factor agreed upon by clinical educator and the medical resident reflect the characteristic of entrustment-based supervision decision and the feedback receptivity across specialty. Interestingly, considering that the factors are consensus-based, they represent a 2 separate but complementary mindset between clinical educator and the medical resident. This study also provides insight on an often overlooked issue of the path to teaching and learning in competence-based resident training program. For achieve the transparency in CBME for teaching and learning, we have our result detail will be in the paper recent that it has been published.